Good afternoon,
Hello, have we
everyone,
started?
and welcome back to the Lusaka Apex Medical University Virtual Clinical Educational Grand Round. I'm your host, Ms. Shinondo, here as part of Corporate Communications. Today's topic is a case study of an 11-month-old syndromic infant with complex health challenges. Now, I would like to remind members of the audience that these are presentations for our students by our students. These presentations are for skill set building within our students. Skills such as long case presentation, public speaking, self-presentation, as well as webinar etiquette. This is where our students will learn in practice, not just those who are presenting, but also those who are in the audience. They will learn how to raise their hand, to ask questions. They will also learn how to interact with people online. This is a skill set that can be used in every other area in life. I would like to acknowledge the presence of our professorial team, Professor Njelesani, Professor Lambert, Professor Modenda, Professor Mwaba, Professor Mwansa, Professor Malenga, as well as Professor Emaus, Professor Gilani, Professor Viemba, Professor Basolo, Professor Kumar, to name a few. I would now like to invite our moderator, Dr. Chisanga, to briefly introduce the topic and begin the presentation. Dr. Chisanga, the floor is yours.
Thank you, and good afternoon to all. And I will just ride on the protocols that have already been established. So our students today will present a syndromic infant, and the presentation will basically just be able to highlight some of the problems we get to see with some of these children with multiple medical problems. And also we'll be able to highlight the importance and the need for a multidisciplinary approach in dealing with some of these problems. I want to applaud the students for being brave and being able to take up the challenge of picking up such a complex case. So I think that will be all for me for now. Thank you so much. Oh, and I forgot to say who I am. So I'm a pediatrician and a child health specialist that is based at UTH Children's Hospital in the malnutrition and gastroenterology unit. Thank you. Over to the presenters.
All right. So while our presenters are setting up, it seems, yes, there we go. It seems the screen share is feeling a bit shy, but here we are. This is a lovely presentation. It's quite refreshing. Please unmute the presenters. Thank you.
Good afternoon, everyone. My name is Nawai Patel. I'm a fifth-year medical student from Lusaka Apex Medical University. Today we are going to present on syndromic infants. I will be presenting the clinical history. Presenting I am an 11-month-old infant, female infant, who was born on the 28th of February 2024. The date of admission was on the 6th of February 2025, and the date of tracking was on the 20th of February 2025. The informant was the mother, and this is a self-referral for difficulty in breathing. Presenting complex, this patient presented with difficulty in passing through for 5 months, difficulty breathing for 2 months, and body hotness for 2 weeks. Patient was born at 36 weeks via cesarean section, indicated for maternal hypertension. She had a low birth weight of 2.3 kgs and passed meconium as well as cried within 24 hours. The baby cried after birth. When the mother tried to breastfeed the baby could not swallow and would spill out the milk. Thereafter, she was referred to UTH, where an nasogastric tube was inserted, and the baby was fed express breast milk with formula. She was in inpatient care for the first 2 months after birth, where the mother was told the diagnosis of achalasia cardia, to which an endoscopic dilatation was done, and the baby was able to swallow and was therefore discharged. While at home, the patient will choke and cough regularly when feeding. On occasion, it will be so severe to an extent that the mother will have to take her to the hospital. The patient has had 4 previous hospital admissions. In all the hospital admissions, the patient presented with a similar complaint, and in all the hospital presentations, the mother was told a diagnosis of respiratory pneumonia. At the time of the last hospital admission, the patient presented with a difficulty in breathing for 2 months, which worsened with time. Initially, it was just mild gasping for breath, which worsened to heavy breathing, nasal flaring, as well as an inward movement of the chest. The mother also felt that the baby would have a heartbeat faster than usual whenever she put the baby on her chest. The patient also had intermittent spells of fever for the past 2 weeks, which was not associated with any cough apart from the cough when feeding. No wheezing, there was no night sweats, and the patient would not get tired easily when feeding or would not gasp for air or breath when lying down flat. There is no history of close TB contact. About 5 months ago, the patient started passing stool less frequently, 2 to 3 times a week. When the mother was showed the Bristol stool chart, she would grade it as type 1, which contained 3 to 4 hard lumps of stool, and she also mentioned to have some stains of blood sometimes. The mother also noticed that despite feeding the baby this delight porridge, maize meal, and groundnut porridge, the baby would not gain weight. There was no changes in her appetite. However, the mother mentioned that the patient does not drink much water. There was no vomiting that is associated with this presentation, no abdominal distension or diarrheal episodes. A month later, a laparotomy was conducted and a biopsy was done at UTH for the long-standing history of the hard stools and infrequent opening of bowels. The mother also noticed that the baby was not eating similar to her other children. On further questioning, the mother would describe the baby had a small chin, small mouth, oddly shaped ears, as well as wide eyes. On the review of systems, birth history, respiratory system, cardiovascular system, and gastrointestinal system have been reviewed in the development of symptoms. Review of central nervous system. There is no history of seizures, no paralysis, no lethargy, and no abnormal jerky movements. Review of genital urinary system. There is no history of anuria. The urine was normal in color. The mother described it as yellow in color, and the mother noted no issues in the frequency of urine, and it was not stained with any blood. Musculoskeletal system. There is no history of rash, no discoloration of skin, no stiffening of limbs, no limb swellings, no joint swellings, as well as there was no edema that was noted by the mother. Past medical history. The patient has had several hospital admissions for a similar presentation that are reviewed in the history of presenting complaints. The patient is RVD-NR verbally. The patient is not diabetic and is not screened for sickle cell disease. Drug history. The patient was on lactulose, glycerin, folic acid, ceftriaxone 300 mg intravenous once daily, and there is no history of use of any herbal medications. Antenatal history. From all her pregnancies, this is the first pregnancy that occurred with pregnancy-induced hypertension. The mother had 5 antenatal visits. There is no history of maternal illness, fevers during pregnancy, apart from the pregnancy-induced hypertension that started 20 weeks of gestation. There's no exposure to radiation imaging during pregnancy. The mother was screened for syphilis and HIV, which were both negative. The mother took folic acid and ferrous sulfate during pregnancy. Immunization history: the mother did not have the 5 card. However, she mentioned to say that the baby received BCG at birth, as well as 2 other medications at 6 weeks, 2 other immunizations at 6 weeks that she did not recall. Nutritional history: the patient was fed expressed breast milk and formula for the first 5 months of life. She was weaned at 5 months with delight porridge and groundnut with maize meal porridge. The groundnut with maize meal porridge was quantified by the mother, having the groundnut being 60 grams and the maize meal porridge as 250 mils. And the baby will finish a full cup of delight porridge together with half of a cup of the groundnut and maize meal porridge. The baby will also have expressed breast milk and formula twice daily. Developmental history: gross motor: the baby is able to move head from side to side, but is unable to sit, crawl, or stand. Fine motor and vision: the baby is noted to track her mother with her eyes. However, the baby is unable to grasp on objects. Hearing and speech: the baby turns head to sound, but only cries with no audible mono or di syllables. Social behavior: the patient will smile at her mother, but does not play imitative games like clapping. Family history: the father is 44 years old, RVD and RR verbally. Mother is 35 years old, RVD and RR verbally. This is their 5th child of the parents. This is their 5th child and the first one to present this way. There is no history of similar presentation in the rest of the family. There is no history of diabetes, hypertension, sickle cell disease in the family. Socio-economic history: the father works as a clearing agent at Chirundu border. The mother stays at home and looks after the family. The mother stopped school in her 9th grade. They live in a 3-bedroom house with 9 occupants, and they use borehole water and flushable toilets, as well as both parents do not drink alcohol or smoke tobacco. Summary of the clinical history: presenting IM, female, 11 months old, non-achalasia cardiac post. Presenting IM, female, 11 months old, non-achalasia post-endoscopic dilatation, RVDNR, who was born with low birth weight of 2.3 kg, who presented with recurrent episodes of choking and difficulty breathing associated with fits, as well as fever and recurrent hospital admissions. The patient also presented with bowel movements and heart stools, poor weight gain, and notable global developmental delay, and an unknown immunization status. Our impression was known patient with achalasia cardiac post-endoscopic dilatation with 1. aspiration pneumonia, 2. failure to thrive with developmental delay. Our differentials are congenital megacolon and gastroesophageal reflux disease. Thank you, and I would like to call my colleague.
Good afternoon. My name is Mustafa Yassin Adam, fifth-year medical student from Lusaka Apex Medical University, and I will be taking you on the physical examination. I examined the infant lying in bed, not in obvious respiratory distress, with an infant in O2 saturating at 100% with a cannula in situ. On the right foot, patient was weak, ill looking, febrile to touch with a temperature of 37.8 degrees Celsius. With a capillary refill time less than 2 seconds. Patient had thin and loose hair and was revealed. Patient had thin and loose hair, levered anterior fontanelles, white set eyes. Patient had pallor +1, but no jaundice or cyanosis. Dysmorphic features noted: unusual folded ears, wide set eyes, low set ears, and a small chin. Anthropometry interpretations: the weight for length was -3 standard deviation, and the near of 10 centimeters indicated severely wasted. Length for age of -3 standard deviation indicated stunting, and the occipital frontal circumference for age of -2 standard deviation indicating microcephaly. Further, the central nervous system, the patient was alert, able to move their head from side to side, was unable to sit without support. Cranial nerves done 3, 4, 6 for eye movement correlate, no obvious nystagmus. 2 and 3 for pupillary light reflex and was positive. 5, 7, and 9 for symmetrical cry with no obvious facial asymmetry. Cranial nerve 8, patient started at loud sound, but vestibular assessment was not done. And for the 10th and 9th cranial nerve, the infant can swallow. Per the ear, nose, and throat, there was no discharge seen in the ears. There was no more nasal bridge with no irregular features of the nose. Normal throat appearance with normal tonsils as well. Our patient was tachypneic with a respiratory rate of 52 beats per minute with no underlying skin. Trachea was centrally located. Chest was symmetrical and moving into respiration. No grunting, no nasal flaring, no intercostal or subcostal recessions. Vesicular breath sounds were heard with no added sounds. In the cardiovascular system, there's normal underlying skin on the chest with warm peripheries. The pulse was regular, full volume, and unbounded, with 166 beats per minute, which was tachycardic. The radial and radial synchronicity, as well as radial and femoral synchronicity, was appreciated. Apex beats palpated in the first intercostal space, lateral to the mid-clavicular line. S1 and S2 were heard with no issue solved. Per the gastrointestinal system, the oral cavity was normal, the abdomen looked full. The laboratory scar was noted 2 centimeters below the umbilicus. The abdomen was soft and non-tender. Shifting downwards was negative, no organomegaly or palpable masses. Bowel sounds were heard and were normal. A digital rectal exam was not done, however. Musculoskeletal system, no edema, no dermatosis, reduced muscle mass, as well as hypotonic limbs, no notable limb abnormalities on the hands or digits. Per the spine, there was normal curvature with no dimpling. In the genital urinary system, there was normal female genitalia noted and appreciated. Bedside tests, urine analysis was not done due to the patient not being catheterized, and it was hard to obtain a urine sample. And the random blood sugar test was also not done due to the inability to find any strips. In summary, I examined an infant lying in bed, noting obvious respiratory distress, ill-looking, wasted, small and short for age, with pallor 1+ and dysmorphic features. Infant was febrile with notable respiratory distress with hypertonic limbs. There was no sign of grunting, nasal flaring, intercostal recessions, subcostal recessions, cyanosis, jaundice, dermatosis, edema, with normal abdominal findings. Our impression is a syndromic infant, post-endoscopic dilatation for achalasia cardia with 1, severe acute malnutrition with stunting, 2, global developmental delay, and 3, aspirational pneumonia, with our differential diagnosis being congenital megacolon, also known as Hirschsprung's disease. Thank you.
Good afternoon once more. My name is Mariam Mubanga, 7th year medical student at Lusaka Apex Medical University, and I'll be running you through the investigations. Based on the history and examination of this is the patient that will be managing for aspiration pneumonia, severe hepatic malnutrition, constipation, and Hirschsprung's disease. The following are the investigations that were done at University Teaching Hospital, where the patient was admitted and the malnutrition was in the line as follows: a full blood count was done, which indicated white blood cell count was high, indicating this patient had an infection. The hemoglobin levels of this patient were low, indicating this patient had anemia, and the mean vascular hemoglobin of this patient was also low, indicating this patient would be having anemia due to nutritional deficiency. And lastly, the red cell distribution period was high for the patient, indicating this patient had anemia, which could be as a result of the deficiencies as well. The second investigation that was done for this patient was a malaria parasite test, which was also negative. An HIV test was done on this patient and it was negative. Prior hospital records were unavailable for this patient. The following are the investigations I would do for this patient. Firstly, I would do a blood count, and with the blood count, I would like to check the well-being of your patient and check if this patient has anemia or other infections that they had presented with in the previous blood count evidence. I will also do an inflammatory marker test where I'll check for the ESR, the erythrocyte segmentation rate, and the C-reactive protein to CRP. So, in this patient, these markers help to will tell us if this patient is having a chronic infection or an acute infection. So, if the CRP of this patient is greater than 10 millimeters per hour, that will indicate the patient is having a chronic infection. And if the that's for the ESR, and if the CRP is 10 milligrams per liter and is greater than 10 milligrams per liter, that indicates that this patient is having an acute infection. Thirdly, I will do a blood culture for this patient. So for the blood culture, this will help me identify the presence of bacteria and the blood of this patient. I'll also do the gastric lavage and the urine lung for this patient, taking in mind that this patient is one that has been having recurrent hospital admissions, so it's also at risk of having infections like TB. So I'd also like to know those infections. I'd also do a renal function test and a renal function test to also assess how the liver and the kidneys of this patient are functioning. I would like to check for the liver enzymes. If the liver enzymes are elevated in this patient, that will indicate that this patient is having an infection. Then, and also if the urea creatinine are high in this patient, that will indicate that this patient is having issues with their kidneys. Then, not last on my list, I would do serum electrolytes. I'd like to check the serum electrolytes of this patient. Know that this patient has been diagnosed with severe acute malnutrition, so I'd like to check for the sodium and the potassium of this patient. And lastly, on my blood investigations, I'll do a urine microscopy and sensitivity test to also rule out infections. Going to my imaging investigations that I would do. So I will do a chest X-ray for this patient. This patient presented with severe aspiration pneumonia. So this is one of the gold standard tests I will do. Then if this test is after doing the X-ray, I will check for consolidation on the X-ray. I'll also check for air interference and lung infiltrates. That will tell me that this patient has aspiration pneumonia. Then I would also do an echocardiogram for this patient, taking in mind that this patient is a syndromic baby, and so I would like to check the heart of this patient and to rule out congenital heart diseases. I'll also do an abdominal X-ray for patients. This patient has been presenting with constipation outset for this patient has been having constipation for like 5 months. So I'd like to check if it's fecal infection, and HCAM is one of our differentials also. So I'd like to check for how the intestines are of this patient. And lastly, I will do an MRI and CT scan of the brain, check if there's any insult that is causing this global developmental delay of this patient. The last investigation I would like to do for our patient is genetic testing. So this is a patient who's presented with syndromic features. So genetic testing would help us know if there's any chromosomal abnormalities and will help us and explain what the syndromic features. So the types of tests that we do currently in Zambia, only karyotyping is done, but then in more developing countries would do a full enzyme sequencing, and target gene panels and chromosomal microarray analysis. Thank you very much. I would like to welcome my colleagues.
Good afternoon. My name is Kush. I'm in my 7th year of medical school at Lusaka Apex Medical University. Today, I will run us through the management of this patient. As we know, with most syndromic patients, it has to be a multidisciplinary approach. So the immediate complications we have at the moment are the aspiratory pneumonia and the severe acute malnutrition. But we have to bear in mind that this is a patient that needs so much support from her mother, from her caregiver, from the doctors, the pediatric surgeons, from nutritionists, occupational therapists, physical therapists, as we will review shortly. So for the pneumonia, we will give some supportive treatment like fluid management, oxygen therapy, depending on the severity, and mechanical ventilation if necessary. Antibiotic therapy, we used a dosage of 50,000 international units per kg, together with gentamicin, which is given. So gentamicin is given every 12 hours, and penicillin is given every 6 hours. Just to run you briefly through the severe acute malnutrition parameters of management. So we have the 10 complications that we will review in this situation. Hypoglycemia, hypothermia, dehydration, these are what we're looking out for. The severity is usually in the first 3 days of presentation. So hypoglycemia is a blood sugar level of less than 3 millimoles per liter. And just quickly, we can see if the patient is conscious, we can give them 50 mL of 10% glucose orally. If they're not conscious, then we can give 10 mL dextrose IV. In this patient, we'll give 10 mL, but the dosage is 2.5 mL per kg. And then we will start giving by nasogastric tube. We want to avoid using a lot of intravenous fluids or any intravenous fluids because this is a patient with severe acute malnutrition. And we know there's fluid overload. We can briefly talk about the dehydration as well. If the dehydration is present, then we use Resomol. The reason we use Resomol is I don't need this one.
Technical difficulties do happen. This is all part of the experience. Otherwise, job well done, presenters. Let me take a quick moment to remind people of the house rules. After this, there will be a question and answer session. You can either ask your question by raising your hand. The floor will be given to you, and you can directly speak with our presenters, or you can write your comments in the chat, and they will be read out for you. Don't forget, this is a learning platform, not just for our presenters, but for yourselves. What are some of the skills? Webinar etiquette. This is a chance for you to learn how to ask your questions, how to give feedback, and how to receive responses from not just presenters, but fellow members of the audience. This is skill set building within our students. I would also like to encourage those of you in attendance to please participate in the next upcoming ones. It's a chance for you to learn as you learn. It sounds strange, but learn as you go. While you are learning with regards to medical education, you are also learning while you are practicing. Learn as you learn as you go, everything.
Thank you so much for talking. As we set up the PowerPoint, I think I can continue the management. I'll just be more descriptive. So now we can start talking about the long-term management of this patient, or rather of a syndromic patient, our approach. So parental counseling is one of the top parameters of our management because the parent lives with this child, or the parent or the caregiver. They're discharged from the hospital when we correct the complications if we can. But it's very important that the mother knows. Okay, please, sorry, just one moment.
Yes, thank you. Kokenga, thank you for muting your mic. Please, those of you in attendance, please mute your mics. Thank you.
So we would give respiratory support if there's a complication. As my colleague mentioned, cardiovascular problems are one of the top issues we face with syndromic babies. These statistics are something I read, but you don't quote me. We know that Edwards syndrome can present up to 90% of patients can present with congenital heart disease, where in Down syndrome we see up to 50% of patients presenting with congenital heart disease. Nutritional support, as we can see, this patient is stunted. It's very severely malnourished, and we would make sure that the mother knows how to look after the child, how to feed them, because the normal diet may not be sufficient for this patient. Infection prevention is very important. This is a patient with an immunocompromised state, so we would give some proliferative antibiotics, malaria prophylaxis if they're traveling to countries without malaria. And then lastly, we would give pain management because no one wants to see their child in pain. So developmental issues we are seeing, the global developmental milestones, the global developmental recession in this patient, we would have to do regular developmental assessments. We would measure all parameters, cognitive, motor, language development, and try and get them to base a development plan that's suitable for them. So in this situation, we have special needs schools, and we have some special programs. In Zambia, we have a program called Special Hope Network that helps syndromic babies with daily activities. Physical therapy, occupational therapy, and speech therapy is very important if they can afford it. There is some organizations that provide this for free. Finally, we need to counsel the family. So genetic counseling, if we know that in cases of Robertsonian translocation in Down syndrome, we know that the other offspring may also present this way. Psychological support is very important. This is quite a big diagnosis to give a mother or a father. So we would make sure that we give them the important information, like mental retardation is very common in most of the syndromic babies. We need to be honest about it, and we need to tell them the way it is, but we have to try and be gentle with our approach. And then respite care is something we are lagging behind in Zambia. This is a care where you can go on holiday if you're tending to a child with special needs, where you admit them to a center where there's adequate nurses, doctors, should they require attention, and it just gives the parents a break. Because from a story we heard from Professor Somewhere during the lecture, he mentioned that a mother who has had a child for 25 years now, the child was diagnosed with CP, and the mother says that 25 years ago, the child was born, her life ended. All she has done is look after the child until this point. So if we could introduce some respite care centers, it would be very beneficial to all of these parents that are dealing with these syndromic children. Thank you very much. Good afternoon. My name is Benedict Chishiko, and I'll be taking you through the literature review. So, we quite understand this child is a syndromic child who presented with a myriad of problems, and we wanted to look into the achalasia that the child presented with. So, about 10 cases in 100,000 population, they present with achalasia. Then we can see descriptive. Afternoon, my name is Ben Shashiko, and I'll be taking through the literature review. So this bunch presented with syndromic symptoms, and we wanted to understand why achalasia is also involved in this situation. So, reading out the epidemiology, 10 cases in 100,000 population of people have achalasia cardia, and an incidency of 1 in 1,000. So basically, achalasia cardia in children is often linked to other condition causes, which also includes chromosomal abnormalities conditions such as Down syndrome and trisomy 18. Achalasia cardia is a primary motility disorder which affects the esophagus, where the circular muscle of the lower esophageal sphincter fails to relax. So this leads to accumulation of fits and regurgitation. In children, they present with difficulties in breathing, difficulties in feeding, vomiting, choking during feeding, as well as dehydration. The test done to investigate this condition is barium milk and chest X-ray. So when you do a barium milk and chest X-ray, it will elicit a shape like big appearance on chest X-ray, as well as like a cucumber shaped like appearance when you do this too. And then you can also do esophageal manometry. This test confirms the lower esophageal sphincter constriction. So you can be able to see that on esophageal manometry. Then endoscopy basically do it to rule out any malignancies in the esophagus. Then the treatment includes endoscopic esophageal balloon dilatation. This is where they insert a balloon down in the esophagus, and then it goes up to the level of the lower esophageal sphincter, then dilates that area to allow the feed to be going into the stomach. Then they also give botulinum toxin injection. And in this one, they inject it. The botulinum toxin will go on the lower esophageal sphincter and try to interact with the cholinergic receptors. Then it will inhibit the release of excitatory neurotransmitters such as acetylcholine, and thereby relieving that obstruction. Then they also do HeLa cardiomyotomy. So this is actually the better procedure for infants. It involves basically the cutting of the lower esophageal sphincter and like permanently relieving that obstruction. So in conclusion, the incidence and prevalence of achalasia cardia notably with increasing advancement in diagnostic and show significant variation worldwide. Despite the large heterogeneity within the population, further studies are necessary to accurately assess the global incidence and prevalence of achalasia cardia. So in this baby, the baby presented with aspiration pneumonia, and we wanted to also rule out the gastroesophageal reflux disease. Gastroesophageal reflux disease actually occurs as a complication of the endoscopic balloon dilatation, because you have a situation whereby they have relieved the obstruction. Now that area can no longer function the way it's supposed to function, so it can close and it remains permanently open. So you have gastric content that actually regurgitate back into the oral cavity, and then you have this occur persistently, and then they present with the esophageal reflux disease. So Those are the cases that we looked at. Thank you.
Well done, presenters team. Job well done. Right. So, IT, could we please pan the camera over to our presenters? Thank you. Job well done. Now, before we move on to question and answer session, we have started quizzes as a part of further skill set building within our students. I would like to do a roll call. How many students, you can simply write it in the chat, how many students are listening from any of our campus sites? How many are tuned in? You can simply say Chalala New Campus, Chalala Old Campus. How many are tuned in from our Chalala campuses? As well, how many of us are tuned in from our Chipata site, as well as Kitwe, Kabwe? What about those from UTH, as well as Levi Manawasa and other areas? Please indicate where you are listening from. So we have Webby from Kabwe, Nelly, UTH, Francis, Kabwe, Kukenga, UTH, Helen, UTH, and the answers are flooding in. We have Levi, Chalala, UTH, Levi. There are a lot from UTH. Levi, the number is growing. Jama from Chalala campus. We have Natasha from New Campus. Welcome. Excellent. Now, I would like to divide you into teams. We have 5 questions, and we'll have a UTH group, Levi, we have Kawe, as well as the new campus. Do we have any listening from the old campus or any other site? We still have more from Levi and UTH. Let's see. All right. So if we only have 4 sites, we'll only do 4 questions. Allow me to screen share. Please give me a moment. Are we all able to see this?
Yes.
Excellent. All right. So this first question is going to those in Levi Mwanawasa. Are you ready? Right. So, 1. Which of the following is not a risk factor for a child associated with developing severe acute malnutrition? A, HIV infection. B, mother who is HIV positive. C, male gender. D, illiterate mother. Or E, tuberculosis infection in the child. So we can have a response. Do we have any responses in the chat? Okay, the answer here is okay. Okay, all of you are saying C. Please give me a moment. I'm struggling with my screen share. Let me pause. Excellent. Please give me a moment. I wouldn't want you to see my scrolling around as I look at the answers. Yes, the answer is C. Well done. Right. Next group. Next group will be UTH. Are you ready? Okay. Are we ready? Great. So this is for UTH. Concerning ready-to-use therapeutic feeds. 1. Can be used in the management of children with moderate acute malnutrition. B. A past appetite test denotes a child's ability to finish 1 sachet of RUTF in 24 hours. C. Each 92-gram sachet has about 500 Is this kilojoules of energy? Is this calories? I believe it's calories. D, can only be used on patients who are in inpatient care. Or E, its nutrient composition is very different from F100. Okay. So this is for the UTH site. Check the comments. Do we have any answers? Also, I would like to pause my screen. Please let me know if when I pause it, the screen stops sharing. This is also new for me. Are we still able to see the screen now that I paused?
Yes.
Okay, lovely. All right. Do we have any answers? Do we have any answers for number 2? Those listening from UTH side?
C.
C? All right. That's Mr. Justin Banda. All right. C? Is this correct? Yes, it is. Excellent. Right. Now we have 4. Kawa site. Right. Concerning vitamin A. A is essential for bone mineralization. B, hair discoloration is a typical feature of deficiency. C, plays a role in mucosal epithelialization. D, is a water-soluble vitamin. Or E, hypervitaminosis A is associated with night blindness. So this is Kawa team. So let us see. The correct answer is E. Sorry, my apologies. The correct answer is C. C. Plays a role in mucosal epithelialization. 4th question. Which of the following is true? Please give me a moment. I realized I omitted a word. There we go. Which of the following is true? A, A mid-upper arm circumference of 11.2 fits the WHO definition of SAM. B, a weight for age WFH of Z score of less than -2 SD denotes stunting. C, chronic malnutrition and severe acute malnutrition cannot be present in the same child. D, children with edema 3+ with a good appetite can be managed as outpatient. Or E, to determine failure to thrive, FTT, one must consider height. One must consider height. Do we have an answer? Let's see. Okay. Correct. The answer is A. All right. So as a bonus, would we still like to go through the 5th question? Speak from your chest. I can't hear you.
Yes.
Excellent. Are we able to see the 5th question?
Yes, ma'am.
5. Which of the following is not part of the WHO 10 steps of management of children with severe acute malnutrition? A, treatment of hypothermia. B, correction of electrolyte abnormalities. C, sensory stimulation. D, growth monitoring. Or E, correction of malnutrition deficiencies. Do we have any takers? Everyone says D. That is correct. All right, job well done. You may applause for yourselves. No, well done, well done. So we had Levy, UTH, and which site had number 4? Which site had question number 4? Was it Kawe? Great. So, job well done. You got that correct. Now, question and answer session is now open. Please, there are no right or wrong questions. This is your chance to explore. And who knows, whatever question you ask will open the door to broader discussions, thus more will be learned. You can ask your questions by raising your hand. The floor will be given to you, or you can write your questions in the chat. And if you take long, I will start calling names. We have Helen Yambe. In drug history, why was glycerin given to the patient?
So glycerin is one of the agents that will help the gut motility to increase. Since this patient has got constipation, glycerin is one of the drugs used in constipation that will ease for the patient to pass stool easily. It can also be given in old age people, and it can be used. It's a safe agent.
Great. So, Helen, please give feedback on that answer. Otherwise, well done, presenters. Okay. Please, the floor is open. This is your chance. Ask as many questions as you can. I would also like to find out for our presenters in the room, do we have any members of the professorial team physically present?
Yes.
Yes.
Okay.
Okay.
IT, can we please see?
To say something?
Yes.
Oh, thank you very much. Madam Shinondo, this is the one of the very well presented condition, complicated condition. I think pediatricians are at home with it, but the presentation was very good. I think well organized. On the history, I wanted to comment that on the history, it came out very well. But when you get any congenital situations like this, including history of the pregnancy, how the pregnancy was managed, and the delivery time, labor, how labor was managed up to ABUCA score. I think the pediatrician, the dean, will agree with me. We needed to know about the history of pregnancy itself, delivery time, and after delivery, how was the ABUCA score for the baby? Was it a flat baby? What was it like? So on history, physical examination again was very well done. But please, as the students, always, we usually, our side of the story, for the 7 days, our 7 days, we were saying practice when you are presenting history, examination, always go for inspection, on palpation, on percussion, on auscultation. So in this particular case, you had a problem of malnutrition, acute malnutrition, and eventually found out that obstruction was there, achalasia of the cardiac, and frequent recurrent aspiration of this baby. You should have not closed your mind just achalasia of the cardiac. Remember the embryological development of the respiratory tract and the gastrointestinal tract. They are very closely related. Go and check in Grey's Anatomy about the development of upper respiratory tract and the upper gastrointestinal tract. They are very related. When there's always aspiration problem like this, have in mind, maybe achalasia only or tracheoesophageal fistula. So something you should combine in your thinking. And if it's aspiration, and you are examining the patient with recurrent aspiration, you should inspect how is the chest expanding as the child is breathing. How do you compare the right side and the left side on inspection? On palpation, also you want to palpate the sound, as the child is crying. Percussion, you can do the same. In the case of fluid collecting, you percuss, is it hyperresonant? Is it, reduce the percussion sound? You report. Then, when you combine the movement of the chest on inspection, you also use a stethoscope, listen to corresponding areas on the right and the left, and report as such. You did a very good report on cardiac apex beat. I was very happy, the one who presented that. It's important to know. You relate them. So, and also in a case like this with so much constipation, there was a special mention I was waiting for about the anal area status. Was the opening of the anus normal, or was it imperforate? You must think of that, especially in a child with constipation so much. So your examination is incomplete until you make a note mentioning about the annual status. Then when it came to abdominal examination, we were very good. But I was waiting somebody to say, was this child dehydrated? Was there severe dehydration? How do you assess dehydration? This is an 11-month-old child. Is the anterior fontanelle still open? Why can't we comment on anterior fontanelle? Well, the closes at 18 months, isn't it? The posterior one, the one closes at 9 months. But the anterior one is still there. You should say, is it sunken? Is it soft? On palpation? Mention. So you are looking at the child from head to the bottom end. Dehydration, you also need to comment the skin tiger, for example. Do all those as you examine. Practice now. This is your time practicing how to do a good history, good examination. But your confidence when presenting out very high. Every one of you, just great. When you talk about investigation, split them into two. Diagnostic ones and general ones. Like the full blood count, anemia, all those are general. But which one do you have done if you are suspecting achalasia? Which diagnostic investigation? And if somebody mentioned barium male. Now, when you are looking at the, I don't know, things have not changed. I'm sure it's the same. When you are looking at esophageal lesion, you don't jump to barium male. You do with it barium swab. Because it's a lighter and a small amount you are following, it will give you esophageal diagnosis. Then I'm not sure in pediatrics, and the dean is here, whether we are able to do endoscopic examination for children of this size. Do we have the endoscope equipment, like in the child, the hospital now called pediatric area? Are we able to do endoscopic examination? Well, if we are, then achalasia of the cardiac can easily be diagnosed. And then when you diagnose, in the treatment you mentioned the irritation. That was very good. Because if you have diagnosed it endoscopically, do you have a esophageal tube which can inflate the balloon and open the achalasia of the cardiac? Before you think of Herod's operation. And also, you mentioned the Herod's operation, that's very good. And the Herod's operation, you serosa, you cut. Muscular layer, the sacral muscular layer, which is clothing, is not open. You cut it, but don't cut the mucosa. So as a surgeon, you must be really meticulous. Otherwise, you open the mucosa, you cause it spillage now. So Herod's operation, you mentioned it very well. I was so happy that, and also nutrition of the core. I'm not sure whether we're able to do parenteral feeding now. If we are able to do parenteral feeding, it will help this child. And NGPs and all that, which you mentioned very well, and the mixture of different types of foods. In Zambia now, I'm sure we're encouraging mothers to feed breast milk for the first 6 months, isn't it? We'll call it breast is best for the 6 months. And after that, you can start mixing. But in this child, I think they started mixing very early because they were worried about the weight. The child is not gaining weight. Child is weak. So otherwise, you presented very. You are coming up with very good practitioner in the health sector. Please maintain that. Thank you.
Thank you, Professor.
Excellent. Thank you, Professor Lambert. I would like to invite our Dean, of Medicine, Dr. Nchimba. Please, I'd like to invite her to the floor.
Thank you, Madam Shinondo, and well done presenting team.
Thank you.
Yeah. It's a beautiful presentation. And you know, I was there listening to you. It's beautiful as we learn, but really, for that mother, that is one child that she wants to get better. And so the introduction of a multidisciplinary team comes very handy because we find that mothers have problems that they've listed out. When we have not sorted out their problems, it means that we have not helped them up the avenues. And so when we get into a team that looks at how is the feeding of this child? How can we improve the passing of stool of this child? What is happening to the weight? This child is not growing cognitively. Who is going to help them with the mental improvement of their mental faculties? Yeah, so I have a number of things also that I would just like to say. Number one, probably just a few corrections. Mental retardation. Mental retardation, all those are no longer medical terms that we use anymore. Because they are offensive, they are degrading, they are no longer accepted in medical space. And so, because they have a negative connotation, isn't it? You can't really put such a large diagnosis on someone that you have no part of having them that way. So we use terms like intellectual disability to sort of describe what is going on with their situation. Learning impairment, for instance. Don't say mental retardation, those. There were words as bad as offensive as idioms in the DSM, in the earlier DSM description, but let's move away from that and use terms that are more appropriate. Also be careful with nomenclature in terms of standard units that we use. If we're going to say hemoglobin, make sure that you are giving us the correct one. If you go to say grams per deciliter, for instance, CRP is milligrams per deciliter. All together. Same with words. Medical terms have meanings. Wasting and severe wasting cannot be used interchangeably. So in your write-up, when you're doing the physical exam, it was clear to everyone that this is, was it even like -4 ST, like when you look at the rate, it was really bad, isn't it? So that is severe wasting.
4.7.
Okay, I don't know when you went to the standards. Yes, so it was obvious that this is severe wasting. So when you come to the final summary that you write, don't say wasting, just say severe wasting. And understand the difference between wasting. So wasting is -2 standard deviation of the same parameters. You're looking at very wide. Severe wasting is -3 standard deviation. It means that someone has just become even more wasted, isn't it? That is different from somebody who is underweight for age, because now you're using different parameters. It's weight for age. So when it is -2 standard deviation, weight for age, that's what? Underweight, isn't it? If it's -3, then that becomes severe underweight. Same with stunting. Your child was obviously severely stunted because it was less than -3. So it can't be this child stunting. It is more serious and it requires more intervention to give the degrees and give them the correct thing. To say this one actually was severely stunted because the standard deviation was even more removed from what is normal. So that's very, very important. Now, what are some of the things that I expect to be probably talked about later in the, starting from the history, the history of, the nutritional status of that child. You got us delights, porridge, and you were very good in that. You actually showed us that the protein content of that porridge, the groundnuts was much less than it should be, isn't it? Because it should have been more than the living. So already there's a problem there. But I expected it to be a bit more expanded. At 11 months, you expect this child to have at least 3 meals a day, maybe a few snacks in between, together with the breast milk. We talked about the breast milk as well as the formula. that was good, but I expected you to tell me more, especially that this is a child who has been seen by doctors for constipation. What kind of foods have the doctors prescribed in terms of trying to make his teeth softer? Has there been any intervention in that? Because that's when a child comes with constipation, that's the first thing that doctors will do. They say, no. Let's give them foods that have bulking agents. Let's give them foods that have got roughage. So lots of vegetables there. If you're talking about porridge, you're talking about mugaiwa. You know mugaiwa? Yes. If you're talking about delight, I want you to tell me what delight, because delight is the weak one, isn't it? There's also the normal one if needed. We want to know what are the details of that nutrition. So we need to expand it data so that we understand his nutrition in the context of his condition. That's that for me, that was very, very important. And then lastly, we have ended up saying this is a syndromic baby, and we really haven't put out any syndrome, so to speak. And so I went out and looked for a combination of achalasia cardia and Hirschsprung's, what we call congenital liver colon. And by the way, there are not many cases out there. So it could be onto something. There's a study that was done in I think it says 1990, I can't remember the year, but maybe some like 15 years ago. And he put out, so this is actually a case report kind of thing that you could put out, because he put out siblings, familial achalasia, so they have both achalasia cardia as well as Hirschsprung's disease, and their brothers, and they had this condition. And so you may want to go into literature really and look out for similar conditions to this child, because it could be one of those rare ones. They went out and did genetic studies and whatnot, so it's important for you to actually follow up and see where we get. There could be conditions that are associated with achalasia on its own. There could be some that are associated with congenital colon on its own, but that combination and a few other things, you may need to actually go back and just see, because it may actually be one of those rare things that we could write about. Dr. Andrew, I don't know if Dr. Andrew is still on the call, but yeah, very beautiful case. Please let's help this child. I'm happy that Push talked about fluid management in severe acute malnutrition. And everybody on the call, you should know that we are always asking this question. And so in 2 weeks' time, we have exams. Make sure you know that the way we manage children with severe acute malnutrition fluid-wise is very different from the way we manage those who have got enough muscle and cardiac muscle to handle fluid. So be very, very careful. Otherwise, you're done.
Thank you.
Hello.
Welcome, Dr. Chimano. And first of all, thank you. Thank you, Dr. Chimba.
Yeah. Thank you so much, the facilitator, and I'm glad to have this opportunity to commend the team from pediatrics, which gave us a learning point. And I was almost forgetting pediatrics, but I've remembered. I'm sure I commend Dr. Chimba. There is an umbilical cord which links us, the two departments. Remember, the obstetrician, good obstetrician will make life of the pediatrician better. Why am I saying this? If I remember well, when they were presenting on the history, which was well elaborated, but there was one thing which was not well elaborated in terms of APGA score. APGA score. I know those who have passed the Obs-N-Gyn, I know that they will come, who haven't passed, but they will come. APGA score is an important element which is supposed to really describe the condition in which the child was born. But the only thing I heard, it was the child cried. Crying, it's one of the factors in evaluating a baby which is born. So that was incomplete, and it may not give a clear picture on the assessment and the development of the child. Remember, The APGAR score was not well evaluated. Even the future growing of the child will have a lot of implications. Yeah. So I just wanted to put up that comment. If they had said the APGAR score, it means a lot. Rather just mentioning that the baby cried. The only problem, how do we start collaborating and have the record shared as you are doing such a case? It will expand a lot of information which will help us to give more light in a presentation such as this one. It wasn't a question, but I wanted to put a comment. If they have a clear APGAR score, I'll be more happy, and it will show that they visited our department to know more information about the child. Thank you.
Thank you, Dr. I'll require you to respond to that. After school, it's coming for the second time.
Yes.
Would you like to say something?
So we had no previous, Mary mentioned, we had no previous record of this patient's information. The patient has been coming to the hospital very frequently, but all of the surgical records were not there, the birth records were not there. And APGAR score is not something the mother will remember. She probably doesn't even know what it is. So we did try to ask, but next time we'll make mention that we tried to probe further on the APGAR score, but the information was not available.
Well said, and I agree with Dr. Chiman and the prof that it's important to be a little bit more well-rounded, even if you may not have records. So one of the other things you could have told us was she was immediately able to circle, because that tells us about the tone of that child, that actually that this child was not born with some asphyxia of some sort. She cried and was put on the breast and immediately was able to latch on and pull away. So that would have also helped us. Other things that would help us think that this child was actually born okay with things like birth weight, which we gave up was like a low birth weight. 10, was it a 10 baby? Was it 37? 10 is 37 to 40, right? So you tell us. So those are some of the things that you could get from the history. So, okay, what was your LMP? And then you can calculate the gestation correctly 2 weeks, not max, but 2 weeks. So all those will not give you the APGAR score, but at least they will give us a bit more assurance that actually this baby, when they were born, they were not bad, or the problems already were shown. Okay, so I agree with them that the birth history, you gave us the birth has never been cheaper, but the birth history did a bit of that, but may not be able to tell us the APGAR score per se, but at least more, information around the birth to give us an idea that indeed this baby was well. So they have a point, but yeah.
Thank you.
Very, very good. Madam Shinondo.
Yes, Professor.
Okay, no, I wanted just to say the point that our dean has said. You can go where was the child delivered. And if you want to get more information, you go to that place. And you can even have a labor ward. We have entries at the labor ward. How this child was born, which day, and what was there. They record even APGAR. But from the mother, if it was a spontaneous vaginal delivery, she was fully conscious. She can give you some information. The child cried immediately, and as the dean was saying, breastfeeding was actively so soon after delivery. You have an impression of what happened during the delivery time. But I wanted to say that, have you seen that we have innovated? Now we are putting in a quiz for every grandparent, and it's an innovation. And you have done it very well. And if Madam Shinondo is mastering it, we have scaled it up now. It's not just a grandparent. There's a quiz. We want to compare within ourselves how our students are handling the issue of quiz at the end of each grand round. Internally, but later on, we may want to attract other universities. We do inter-university quiz after the we can reach that level. And later on, we are linked to universities in Nigeria, in Uganda, Tanzania, Australia, Norway. We may develop to that level where we announce we are going to have this grand round and we shall end up with quiz, so that we link up with students elsewhere and compete with them, how we can handle quiz. We want to internationalize this program of grand round. At the professorial level, we have already done. A lot of professors outside are participating. So, but the student level, we want also to penetrate that level and see how we can interact with the other university students in your group of studying medicine. And not only medicine. I think preclinical is attracting more professors than medicine. But then we have to work hard on medical science. Preclinical, anatomy, physiology, pathology, we are attracting more professors participation from outside Gambia. So let's pull ourselves to see our Professor Girani in Pakistan, he should be taking part. The professor in Australia and the Madam Nina in Norway, they should be participating, especially in medical programs. So we have to enrich it. But what I want you to be doing is rare cases condition. When you go to Kitwe, Kawe, UTH, Levy, try communicating, gathering information in topics like this, so that you start preparing your own alumni groups, which you will not do touch on, and you start doing multi-facility study, and you start writing at your stage. You should start writing. Become powerful people, publish, start publishing as soon as you finish, And remember years back I was saying you either publish or you perish. So I think remain publishing. But it's information collection and the aim at becoming the top practitioner, which to compete, not just in the region, but globally. You are the brains who are going to uplift healthcare globally. Thank you very much.
Thank you.
Thank you, Professor.
Dr. Ms. Olga, I was going to say that Dr. Chisanga is off to another meeting in the next 10 minutes, so maybe you could allow him to speak before it drops off.
Yes, please. Yes, Dr. Chisanga, as our moderator, the floor is yours.
Thank you so much. Although because I was up and about, so I kept dropping in and out, but I just want to say a huge congratulations to the presenters. I think job well done, and as I said earlier, it was brave of them to pick such a topic. Usually these are topics we would discuss with the postgraduate students, but it was good to have undergraduate students take the leap of faith, in trying to present this particular topic. And I believe it was also a learning platform for them as well, in terms of history taking and connecting everything together from history and examination, as well. So I think thank you so much for the platform as well, and kudos to the team as well. Thank you.
Thank you.
Thank you. I would now like to invite closing remarks. Let us begin with our presenters team. The floor is yours.
I'd like to take this opportunity to make my heartfelt gratitude to everyone that has been here, the professors that are online. We're really grateful for this opportunity. As the professor has told us right now, you either publish it or you perish. So we have learned that. And I'd also like to thank the dean, Dr. Nchimba, and the other deans here. We're grateful to Dr. Nchimba for this opportunity. It has been a great opportunity for us to learn, and we're so inspired by you. Then I'd also like to thank your moderator, Dr. Stanga, for taking his time as a pediatrician to take us through all the history. He was very helpful. He took his time to run us through everything, and we're really grateful for him. And then I'd also like to thank my fellow presenters here. I haven't been easy working with them, and so I'm grateful to this team that they helped me. And my fellow students who are listening online from Kitwe, um, Cowboy, and within Lusaka, I'd like to say thank you for attending and take part in going on with so we're really grateful. I would like to see the Kitwe team present next time and in the future. And lastly, I'd like to say thank you to the organizers. Ms. Olga, she's been very helpful to understand how everything is done. And even the IT, we are grateful. Thank you very much.
Thank you, top well done presenters. Thank you so much. I'd now like to invite, our moderator already gave his closing remarks, so I would like to invite our professorial team to give theirs.
Well, just to say thank you very much. I hope, I'm not sure whether the BC is attending. If he's attending, we should allow him to speak. Our CEO, Professor Peter Mawa, is also a very good person to attend, and the other professors. So on their behalf, if they are not there, is to thank you. Please maintain this momentum. Pediatrics is so special. Please take care and make sure you understand the child. Well, this don't give history. It depends on the mother or the father at the time. But do a good history for the baby and do a good physical examination from head to toe. Examine and master how to pick this sign. This baby is a gift. So maintain that. But as the university wants to build on the grand rounds and the quiz now, and please, when you go, prepare for the next presentation. If people are lazy, come again. There's no limit. Come again. Just come to this page. You are practicing very well on how to present. Our university is aiming at qualifying high quality graduates in all fields. Make sure you are improving your transcripts. Please, we are tired of C's, D plus I. We are aiming at our students calling because they know what they're doing. They score high so that the transcript, when you get it at the end of the training, you can show it wherever you will be that this was your academic record that we achieved. That's why you have seen we want our teachers to show us what have they prepared to teach our students. We want topics, summary of contents, where and when you are going to teach. At the end of each topic, 4 MCQ questions and 2 short answer questions for every topic we are getting, because we are following the curriculum to fulfill the curriculum, so that when you qualify, you have it in your head. Depend on brain intelligence. Don't mix it too much with the artificial intelligence. We're training people who are going to use their BI, not just AI. Please. So thank God for this. It was a wonderful time to interact with you. Thank you.
Thank you so much.
Thank you, professorial team. Thank you, Professor Lambert. We have now come to the end of today's virtual clinical educational grand round on an 11-month-old infant with, or rather an 11-month-old syndromic infant with severe health challenges. Now, I would like to remind everyone, these presentations are every day of the week. So tomorrow, we shall have a presentation from Faculty of Nursing to do with ulcers, diabetic ulcers in the leg. Presenters, please don't forget, once this presentation is done, please make your way outside with the professorial team to have your portrait taken. This is history in the making. And with that, we've come to the end of today's session. Please enjoy the rest of your day. You will find the recordings on our LAMO YouTube page. Please and thank you.
Thank you very much.